Hey everybody, my name's Chandler. We're going to be talking about healthcare disparity this evening on Pulmonary Disease Navigator and the Respiratory Educator. As always, Keith and everybody at Respiratory Associates, appreciate you having me here, and I appreciate everybody being here tonight. Couple objectives. We'll review pertinent United States statistics as it relates to our topic. We'll describe health disparity and a few of its contributors, certain factors hindering pulmonary health, and probably a couple of solutions maybe. So the United States healthcare, right? So we'll just dive in here. So it's we have some of the highest expenditure with one of the lowest life expectancies on the charts here now. We have some of the highest rates of avoidable deaths, some of the highest numbers of preventable hospitalizations, highest chronic disease burden, and in general, we have fewer physicians and decent preventative care medicine. So we look at expenditure as it kind of sits now. Expenditure is sitting at an obese, roughly, give or take per the month, 19.7%, according to CMS in 2022, or roughly 4.1 trillion buckarooskies. The Affordable Care Act brought insurance to nearly 20 million people, of course, give or take. But this did not exactly close the gap. So this is one of the things we'll kind of dive into. The Affordable Care Act did extend insurance to everybody, but that did not address, let's say, geographical disparities or things of that nature. So we have to look at it more broadly than just, does this patient have insurance? Well, yeah, can they get there? If they get there, are they able to communicate the right way? So we'll look at a lack of primary care providers. And this means providers across the board in general. And particularly as we move forward, we'll see how age is increasing this expenditure and how there's a huge need for geriatric practitioners. So yeah, a lack of primary care providers. So this is why there is a big push for mid-level providers. Of course, it's a bit cheaper in terms of copays and things like that. There are some restrictions. However, if you can have, let's say, one physician sign off on 20 different practitioners per se, then how can they charge for the physician price? So we'll look at a big push for mid-level providers, and this is one of those things too we'll see with the advanced practice respiratory care, or however you want to say APRT, to also help to close this gap. So health literacy is quite abysmal as well. So I believe the last statistic that I read stated that roughly 12% of the American population is considered health literate. So of that percentage, I'm not sure if that was including healthcare providers or just gen folk in particular. But that's pretty bad. So that's roughly 12% of people, they're not able to use prescription medications the way that they're supposed to. They're not able to understand, let's say, the education that's given to them after an ER visit or at the provider's office. So this is a huge problem. Not just, it's been a huge problem. And this is where we'll see where value-based care may come into hand as well. Because the more time we have with our patients, of course, the more we can educate them. And per our patient population, you'll know how to educate your patients. Loss of healthcare personnel, of course, I believe every one of us have seen this, have felt this, and may have been some of the folks that were going to travel and things like that. But a loss of healthcare personnel, this is a healthcare disparity. So let's say, a patient can get to a healthcare facility, they got to have people there that's going to take care of them, right? So therein lies a gap as well. And we'll see this particularly with rural health as well. Our healthcare system is more reactive instead of proactive. Some folks coin it sick care instead of health care. So, particularly, you're not going to go to the emergency room or something like that if there's not something seriously going on, right? So our healthcare does just that. It says, okay, well, come see us when you're sick, not when you're well. So more reactive than proactive. And there's been a huge technological shift over the past couple decades. So, used to, if you had surgery on your finger or your hands or something like that, they would keep you in the hospital for a day or two, right? So now you can go have that done and be out of a facility in no time. In a couple hours, wait for the anesthesia or whatever to wear off. So this technological shift has somewhat improved access in a way and decreased costs, but in another way, it's a runaway market. So from my studies, we know that there are more regulations with medications than there are with this type of technology as it rolls out so rapidly. And we'll see how this will play a role in rising costs and health disparity as well. So Peter G. Peterson. So everything that I've read and everything I've come across the past couple of years is pretty much on point with it. We can see some of the outcomes here, right? Life expectancy of birth, infant mortality, asthma, diabetes, so on. So you would think for a nation that's spending, $3,800 more, $3,800 more than the next runner-up, that we would have some pretty significant outcomes. And that's just not the case. So as it's stated here, although the United States spends more on healthcare than other developed countries, its health outcomes are generally not any better. Look at safety during childbirth at the bottom left there. I mean, that's pretty rough. So we look at that cost per capita, and I mean, it's a bit outrageous how much we're spending versus what we're seeing on the other side of that. It's a good graph. I thought it was a good graph. So what's driving these costs? So I hate to say it, but it's totally true. The American culture, the American ideology is, we kind of want the best right here, right now, the newest thing, whatever you got, no matter the cost, right? So that's kind of what's driving it. And people know that. Of course, there are marketing tactics and things like that. But, let's take, for instance, a situation where we'll have a MRI, let's say an MRI machine, 2021 versus 2022. So you go up, maybe it's got Bluetooth and an Apple CarPlay or something on it, but that's it, right? That's the only thing different. So you come up and you say, hey, buddy, we got to get an MRI on you. We've got this new 22 edition that, it's got these new lights on it, and you can link your phone up to it. It's $7,000 more, but, and just for instance, making a laugh, but they're going to pick the 2022, and they're going to have that extra $7,000 bid on the back end, the front end, or out of pocket. So the ideology and the knowledge that we're going to use the best of the medical technology. So they're going to keep coming out with it. Pharma is adding to these costs. Particularly, we look at specialty medications or orphan drugs. Some of us may be familiar with, say, OFEV or Entresto. Even with really good insurance, these patients are paying thousands of dollars for these medicines. And really, the idea here is, albuterol is fairly cheap. With insurance, I think mine was like $5 or something, but a large number of people use albuterol. You're looking at OFEV and things like that, and not a lot of people are using them. So the idea is, well, we'll charge more for it, so we'll make the same amount versus, right? Not particularly, but just thinking. Volume-based versus value-based, and we'll kind of look at value-based here in a second. So volume-based healthcare is payment and consumption based off how many patients we see, not how well we really make them. kind of in the back end, you look at readmissions and things like that. But versus value-based, where it's weird as it is, you're getting the practitioner's getting paid to do what they learn to do and what they vowed to do. Let's say a patient comes in, their A1C's out, I don't know, 8, the doctor says, or practitioner looks at you and says, well, we're going to at least get it down to 6 in a month, whatever, however it works. And then they do. Well, they get an incentive on the back end from CMS and all those things. You decrease your utility of healthcare, hopefully, being healthier. And that's kind of with value-based care versus the volume-based care. So like I said, it's sick care right now, with tremendous efforts and funding going into decreasing readmissions and things like that, when there's definitely an underlying cancer that's eating away at healthcare. As we said, the aging population. So in some ways we are living longer, but particularly I won't say we're living healthier. The older population, the aging population, is now utilizing a tremendous amount of the insurance or the available funding right now, and that that's somewhat to be expected. You can't walk around doing backflips at 80, 90 years old, but as we age, we use more healthcare, driving those costs up. Overuse and underuse. So one of the biggest portions of my current gig is driving down readmissions. So I believe statistically, on average, each readmission running about 15 grand out of pocket for the facility, something like that. So we have these patients that'll come in, oh my God, I broke my toe, or I have anxiety, or you have your stage 2 or 3 COPD patient that's finally feeling the symptoms of COPD, and they're scared and panicked and come in over and over and over. Or as we see with COVID now, I've had patients that won't come into the hospital, they'll have COVID, and they'll be in there every 3 or 4 weeks. So this overuse, of course, we know, or the abuse of healthcare, we know is causing a tremendous amount of expenditure, but the underuse as well. You think, well, if you're not using healthcare, how exactly is that driving up costs? So sometimes you have folks that are just so stubborn that their condition gets so bad that by the time they go in to be seen by a provider, they're like, oh my God, we've got to have open heart surgery or something like that. So you immediately are hit with $2,000, $3,000, $5,000, $6,000 worth of medical expenses just all at once. So let's dive into this little bit of this value-based healthcare here. So we look at kind of 4 different things. So we look at patient care data that's measurable, coordination of services, and communication. Well, the patient care and the communication are kind of linked always, right? Provide the patient's clinical grade feedback on their condition and instructions on what to do next. So value-based care is looking at, or even before kind of the VBH plan or approach to healthcare, there was the personal electronic medical record. So I actually have me one now, and it is like super duper cool stuff. You can see like if you're getting meds, if your meds are ordered, you can text the doctor or the provider or whatever. It's really neat. So this is completely interlinked here now, especially with, internet and all those things. So patient care and the communication are very, very, very highly are held on a pedestal when it comes to value-based care, because you want your patient, just like with my patients, the more they know, the more they're involved, the more informed decisions they both can make for each other. With the advent of personal EMR and EMR in general, we have data that is measurable, right? We can look at the numbers, we can look at the patient populations, we can segment, we can dissect. So we look at patient outcomes, engagements, and improvements. I think a lot of facilities use Vizient to do this. They'll look at readmissions for specific disease and things like that. And coordination of care. So it's just like I said, say you wake up one morning, you're a little short of breath, you can text the doctor, right? Provide close coordination of services based on 24/7 real-time data. So the doctor could say, yeah, well, your symptoms are pretty bad. I'm going to call you. Let's see what you say. All right, you need to go to the ER, right? So all of this tries to trickle down with your largest stakeholder, the patient, finally involved with some things to reduce the burden. We try to eliminate disparities, especially when you're looking at accountable care approaches or value-based approaches. Say, have a lot of programs in play for transportation, plans in place for food disparities and things like that. So you can use all of these community resources. You can use all of this data that's charted through and track measurable measurable outcomes and the impact that those outcomes are having. And even in this, you can start building community programs to let off from original ideas. Of course, we want to safeguard the public health and particularly public information as well, or patient information will achieve cost savings. And that's the thing. So they'll say, well, I got your A1C down now, you don't have to come here, pay these co-pays. You don't have to try this or this type of medication, this one, so on, so you achieve the cost savings, you find things that work and you stick with it. And there's proof that it works. And improve access for rural communities. And this is this was a big goal for the Affordable Care Act. This would be a big goal for value-based healthcare approach. And it should be at the center, well, I won't say at the center, but it should be held up there in any terms of healthcare approach. And we'll see why in just a little bit. So some of the contributing factors to this, and we're not going to go all the way through this wheel, but we'll look at income, education, geography, race, ethnicity, culture, sex and orientation, behavior, lifestyle, lack of insurance or access to insurance, and religion. So one thing we'll definitely look at here is the financial and the intellectual, because these two things, as we'll find later, are pretty much inseparable. So with our financial disparity, so financial wellness means taking steps to live within your financial means and living and planning for your financial future, right? So the intellectual intellectual wellness means staying curious and engaged in learning new things. So what does it sound like to you? So if we stay tenacious in our growth or in our want for learning, and that's completing one portion of this wheel, generally we've seen in statistics throughout the years, the more educated an individual is, the higher the income that they can expect, right? But this too, you just can't be, have a PhD and make, $130,000 a year, and your geography could totally still be in your way. Your ethnicity and race could definitely be a barrier. So when you look at this whole wheel, for individual wellness, one portion of it missing, and it will not work. Any portion of these things that are impeded on, listed here, and it just doesn't work. It doesn't work out. There's going to be a segment of the population that will continue to experience gaps in healthcare. So one of the biggest disparities, I think anyway, is the healthcare system itself. So Harrington in 2022 stated that there was, William stated or paraphrased, that there is generally no one person or group of peoples that they could pay enough or pay long enough to tell where every single cent of healthcare finances end up, right? So just that in and of itself, one major factor, of course, the financial factor that cannot be completely and fully tracked, that should tell you something about the whole infrastructure itself. So an inadequate medical care system that is very complex and fragmented is in and of itself a health disparity. It has been stated that as patients move across the spectrum, they may contend with fragmentation, poor continuity of care, and insufficient coordination of care for multiple health needs. So that's one of the reasons, I won't say one of the reasons, but as navigation formulates into this thing, into this niche, that is to navigate the healthcare system to figure out where these resources are and taking very specific segments of patient populations and placing them in the right place at the right time where they need to be. This is a huge problem. The people that have created it, the people that are the leaders in these fields now, can't tell you everything. We'll say with their expertise, be it finance or what have you, can't tell you to a T how it all works. As the country has grown unhealthier, the need for an increase in the number of healthcare providers has grown. Makes sense, right? And it will continue to rise. So a lack of qualified healthcare professionals in rural areas will continue to be an issue as graduating providers fill gaps in larger cities. So what does that mean? So I'm a bit of I'm one of these myself. So grew up in a small town, went to school in a small town, used that small town's resources, got an education, and started working somewhere else, right? So the small town facility didn't pay as well or have as good as benefits as the place in the city, so on and so forth. This is what happens to nurses, clinicians, providers, nurse practitioners, all those. That's a big thing here. A newly graduating, done with med school, fellowship, everything, physician may not say, look, there's not even enough people here to sustain a practice. So they leave. Let's say, for instance, they move 2.5 miles away or 2.5 hours away. And that's the closest one. Well, some folks just can't make that ride, so a lack of these healthcare providers is a huge thing. And that's as we see with the plea with, AERC and MBRC and everybody, there's a lack of RTs, folks. We know that. I'm sure some of us still at the bedside are definitely feeling that right now and have been for the past couple of years. So yeah, as we stated earlier, this is a huge disparity itself. It was stated that because the increase in healthcare jobs is expected to outpace growth in all other fields and industries, recruitment and retention will be matters of special interest to all healthcare leaders during the next several years. And that, right? But, you got to look at these, I've worked at a few of these colleges, with those in Tennessee and Kentucky and things, and we look at the marketing attempts on let's say our side, or the marketing attempts for any other profession, and you just don't see it. You just don't see the big rodeo that you used to, and people aren't going to the field. They're hearing horror stories and they're moving away from the field, and it's just not true a lot of the times. Income and education, kind of like we talked about earlier, right? Absolute low education attainment as well as low income are some of the most influential variables in regard to healthcare disparity. Now, I want you to read that sentence on your own while I take a sip of my tea. And remember it. Low income or socioeconomic status is a prominent indicator of health and often associated with health risk behaviors. And we'll definitely talk about that in a little bit too. So looking at income and education, so we know the more education we have generally should be the more income that we have. Generally, the more we work, these individuals have insurances. These folks can understand somewhat healthcare if they've been through biology and things like that, and maybe they have a halfway decent idea, and they can make better, more informed decisions for themselves, right? But one thing that happens, one thing that we see, especially the old Yankee versus hillbilly thing, attribution error and bias, right? When placed in healthcare setting, those that think that of lower education levels in regard to health are blamed for their lower income status and unhealthy actions. And this I've actually seen this happen. Some folks, especially where I was from, they just lived up in the holler. They were happy folks and would get sick. Of course, they were considered to be in poverty and things like that. They didn't have no insurance or anything. And they would be labeled as, malingerers or what have you. But sometimes that's just not the case, but that is the attribution error and throws bias within healthcare, which of course is a disparity itself. Environmental factors. So we know that lower education, generally you will work lower paying jobs, and in many cases, jobs that expose the individual involuntarily to hazardous materials and work environments. One of the big examples I can see with this is, because I'm from Cole County, and you would see when there were layoffs, a lot of the underground workers were being laid off. Not all of them, of course, the mine still had to run, but they didn't really have much else room for growth. They would have to go work at the local factory or, at the grocery store or what have you. Not saying they were unskilled, but they were uneducated for the most part. And this definitely played a role in not only the hazardness of their jobs, which mines were paid decent, but after the fact, they would have to work lower paying jobs. Lower level income housing, which is usually unkept and overcrowded, can expose the individual to communicable diseases, mold, vermin, and other insects. So great example for this being, mother, child, what have you, the family's in the apartment. I always just like picture it in my head, it's just a big old huge city apartment complex. And every time the child's home, they have this wet, nasty cough, maybe a fever going on, right? Wheezing. So the mom says, well, okay, great. Let's just go to the doctor and see what's going on. Every time you go to the doctor, the wheezing stops, the coughing goes away. But they don't think to check for things like mold or vermin and insects that could be causing these diseases, or, of course, community acquired pneumonias. So this is automatic exposure in many cases. Risky behavior. So sedentary lifestyles, poor diets, alcohol, and drug use. So I like to put sedentary lifestyle in there. I guess you could call it a risky behavior. The more sedentary we are, the more unhealthy we generally are. They just kind of waste away, right? Well, a lot of kids are just sitting in playing video games and things like that, staying out of sunlight stuff. And it's dangerous to do that, right? A poor diet, of course, pop and Cheetos, alcohol, drug use, more prone to health risk and factors such as stress, social isolation, environment exposure, and lack of preventative care such as vaccines. So, I kind of growing up where I grew up, we of course we had a lot of video games and stuff like that, but we would always go outside and ride our bikes and scuff our knees up, and probably did have poor diet, eating Slim Jims and the bubble gum cigars that you used to be able to get. But not so much now. And you can even look at the pack of the ramen noodles that says, GMOs and things like that. So all of this can be considered risky behavior. And type 4 dopamine receptor is known to be linked to that risky behavior. I would have to assume it's releasing the pleasure endorphins and things like that. But when you're living in this way, you're not particularly worried about your health. So you're not going to, let's say go get your flu vaccine or COVID or what have you. You're not going to take the necessary steps to take care of yourself. And this may even be that individual that one day wakes up and says, oh my God, I feel like crap, and goes to the hospital and needs, triple bypass or something, So these risky behaviors can manifest early, quick, or late, and I would say kind of get thrown in your face. But preventative care is a huge thing, folks. I mean, it's preventing things, right? I thought this was an interesting graphic here. 2021 life expectancy in adulthood is falling for those without at least a bachelor's degree. but we'll see with less than a degree. What would you call that? I would call that maybe 77, 78, maybe total of about 80-ish. But those with a degree, the life expectancy, it's I would call it pretty significant, 4 or 5, or at least 3 or 4 extra years there. Could that be attributed to making better decisions? Could it be, I would have to imagine that's a good portion of it, or at least be able to understand the methods of their care in medicine anyway. So as we said with education, so the higher the education, generally the higher the income. We can't say, well, just get real smart and you won't never be sick. As we seen earlier, healthcare is very expensive, right? It's it's so expensive in some cases, some people just can't even get it. So take a look at this graph here. Take a drink of my tea. So it's 2017 CMS graph stating a strong negative correlation between median income and mortality rates among U.S. states. So mortality rates on the left are going up, right? And on the bottom, on our x-axis, we have income, and the higher the income, the lower the mortality rates are. Pretty simple graph here, but correlates completely. So we'll see dying slows the more money we make. We go back here, the more educated we are, the longer we live. It's neat stuff. And a huge contributor to health disparity. So, okay, let's say, you're so sick of healthcare disparity that you become a practicing physician. So you graduate, you look around, there's, maybe a handful of people, is going to be your patient or whatever. So you leave. Right, bad as you hate to, you went through all that schooling, did all that stuff, and then you leave. You increase that gap. So this is a geographical gap. So according to literature, barriers to healthcare access vary with geography. Rural areas are particularly hit hard. So especially when we look at, let's say, Kentucky, Virginia, West Virginia, Tennessee, particularly coming to mind. So these are rural areas generally stricken with quite a bit of poverty. And as we will see and have seen and could allude to, poverty is increasing our sicknesses as well. So these folks are coming out with lung disease, heart disease, and all these things. And they're having to travel. A lot of them aren't able to travel. By this time they get so sick, it's a lot of times these folks are so stubborn they just won't do it. So pretty much, as we said, not many practitioners want to practice in these rural areas because there's not a lot of patients to be seen, and generally a lot of these patients are hard-headed. And as we know with our smoking population, they have to get discharged from the ER with smoking cessation in one hand and a cigarette in the other. So it's frustrating to them, I can imagine, as well. So, yeah, but this is not to say that inner city living has its perks either. So, I mean, God almighty, you go to the ER in one of these medical centers, you may be waiting there for, 24 hours, 48 hours. I've had patients being there for 3-4 days. It's like, well, buddy, if you're feeling good enough to sit in the ER that long, try to go to urgent care in the morning or something. And that's just one of those things about the city. People know that they're going to have to wait that long to be seen in that type of situation. It's harder to find providers. I mean, you got to think, you got a new doctor comes in, they get flooded with new patients because those new patients, I tried to schedule an appointment the other day that was scheduled out until April of next year. Couldn't see the provider, a primary care provider, April next year. And in the city, that's just kind of how it is. It's just booked all the way up. And you can't really find anything on the outskirts because they all move inwards. some of the geographical locations have a scarcity of resources. So especially as we've seen with COVID and things like that, these smaller rural hospitals, I won't say we're last on the list to receive things, but when you have 30 COVID people in your ICU versus 300 or 400 in your hospital, who do you think those resources went to first? So these areas are scarcity of resources, and generally they don't. I mean, they make millions and millions of dollars, but in terms of healthcare, they don't really make that much money, and aren't able to, in some cases, afford newer equipment. And a lot of just like some of y'all folks know, I wouldn't want to go somewhere and use a old busted ventilator I ain't never seen before. Like I said, we want the best. We want it right now. Way to go, right? So this attracts new and emerging talent, and they just don't have it. So we look at a lack of providers. You can't have a rural hospital that has the most advanced, let's say, robotic heart surgery and neurosurgery. They only see 2 patients a year, right? They're going to go in the city where they can practice, revise, and communicate with other providers and so on. So the lack of providers, inadequate internet sources, limiting telehealth. So believe it or not, some of these places, you can't get internet up in some of them hollers. You can't, a lot of times you can't even get phone service. So even if we could bring the doctor to you, you still couldn't use it. Now, there are programs that I'm aware of in North Carolina where you could send the doctor. They do home visits still. But I mean, you got to jump through all these hoops, and telehealth's fairly easy. We've got these ways of providing care to these patients. They never even have to leave their home, but now you can't even do it because you're way up in the holler. A limited facility. So let's say you can creep your way up out of the holler and you get down there. I mean, you may still have to drive an hour just to get into town to get to the facility. Inadequate vehicles in some areas. Sometimes they can't even get to you. They have to take a horse to get to you. And all of this essentially is a delay in care, right? This delay in care is increased, it relates to increased mortality. Say for instance, the patient's had a stroke. Well, if you have to drive an hour to get to a hospital, well, your risk of mortality is just through the roof. We can't forget those things when we're talking about access, when we're talking about healthcare disparity, and ethically talking. There should be more focus inward on those things. Those health disparities are things that grew from the inside that have been washed over time and time again. Like I said, it's just a cancer to the healthcare system. So you look inward at these problems and address the needs of that segmented population too. So, I mean, imagine, get my little pen out here. So imagine, all right, let's say we're about right here, right? And there's a specialist that you've got to go see out in Iowa, right? That's the closest one to you. They had some here, but they all band together and went to Iowa. Well, that's a huge disparity right there. In some cases, going from here to here is a huge disparity to some folks. We have to look at those things and say, a lot of the Affordable Care Act, well, I won't say a lot of it, but many of those insurance programs do have transportation built into it. Of course, it's limited in many cases, but they're more than likely not, to my knowledge, are going to take you, say, from the armpit of Tennessee and drive you out to Kansas. I don't think that's, part of the thing there, but that really comes down to facility funding of those facilities and actually getting people in there, getting warm bodies in there to run those facilities too. So the lack of is the lack of. Look at other demographics of health disparity. minorities compared to non-minorities tend to receive a lower quality of healthcare, and this can be stated many, many, many times throughout the literature. It's still, it's just kind of the elephant in the room. Research shows that minorities have higher incidence rates of chronic disease. The issue of race causes bias and stereotyping, which can lead to misdiagnosis by healthcare providers. And on the flip side, mistrust of healthcare information by the patient. And I know we have all ran across that patient that said, I don't want this, I don't want that. Y'all don't even know what you're doing. The ambulance brought me here because I was passed out or whatever, Cultural competence. That's kind of what this comes down to, right? It means being able to effectively understand the behaviors, language, beliefs, and communication methods of other racial, ethnic, and religious groups. Now, in our associate's degree in respiratory care, not that I was taught, but this is a portion of healthcare that we just kind of glanced over for maybe a brief, oh, hey guys, yeah, make sure to read the third paragraph in chapter 7 about culture or whatever. So this is one of those things I think as respiratory, we definitely could build upon and make better within our programs and within our practice in general. Because folks, we see all the patients, right? We're not specifically linked to any type of race, ethnic, or religious group or anything like that. We're exposed to all of them in all of the most vulnerable situations. Patients are like these stakeholders, right? They'll be like Walmart saying, well, I don't really care if our customers really like any of this stuff. Either they're going to buy it or they don't. Patients are your biggest stakeholders. They're your consumers. They're the ones, you look at HCAP scores and things like that and IQRs, then that's the patient putting out a Yelp on a hospital, right? They can actually hurt you a whole lot. Patients play a large role in breaking down barriers to quality healthcare. Prior experiences of racism and the fear of racism or cultural ignorance influences how patients engage with the healthcare provider and utilize services offered. So imagine you go into a facility's office and you are knowingly mistreated because, say, your skin color or your ethnicity or something like that. Well, you're not going to go back. And you may even, get sick and say, well, I ain't going to the ER, buddy. That ain't nothing. They ain't going to do nothing for me because they're prejudiced or racist or what have you. These are huge, huge health disparities and impacts a very, very large population of patients. And you can look at all the statistics, really. We can go back and look at our graphs as well. Ethnicities, there are huge gaps in life expectancy and so on. We'll look at pulmonary health. So we know if we're in a lower income bracket, we're probably not eating the best type of foods. They make all those foods, those unhealthy foods, quite affordable, and the healthy foods pretty much unaffordable. Those in lower socioeconomic standing are less likely to follow established nutritional recommendations, and we know that, right? That's just like out in the mountains. It was a Mountain Dew thing, right? Everybody had Mountain Dew mouth and smoked cigarettes and worked in the coal mines. They did not follow any type of established nutritional recommendations, especially when, after cardiac disease or after, COPD exacerbation, buddy, they just kept going. They're less likely to purchase healthy foods because, generally you don't have the money for it, right? If I'm pretty sure, to eat the way that a lot of those nutritional things want you to eat, you got to make a pretty good amount of money anymore. You're more likely to eat processed products and fast foods. It's cheaper. You probably feel like you get fuller on it, but it's kerosene for your car, right? That's what I tell my patients. Don't put kerosene in your car and expect it to run right. These things modify you on a genetic level, they impact every portion of your body. It's what your body is absorbing. I mean, you can leave a McDonald's cheeseburger out for probably a week and it look the same. And then people are smoking on top of that. I mean, it's just insult to injury. Adding or mistreating your food, mistreating your body with food. And we, of course, we should know by now these processed products, of course, modify us on a genetic level and have been linked to certain types of cancers as well. So we've got pollution already up and abound, right? I mean, that's why there's an air quality meter on our phones anymore. Then these folks are smoking on top of that, modifying their genes with organics that they're placing in their body. And then as we age and our telomeres just wisp away, everything else starts to break down on top of that, and wonder, why they have to have a walker or a fake eye at 50 years old with diabetes and whatnot. It's this here. It's the kerosene. But these folks, somewhat to no fault of their own, either one, they're with lower education comes lower income. Maybe they just don't know, right? Or two, they know better, they just can't afford it, so they're more likely to go without. So there's really, fast food and a couple groceries, or all groceries and maybe skimp on the light bill. And it all, I mean, can you see how all of this is kind of compounding on itself, right? And it really just begins because we all have the opportunity. Well, I would say a good majority of us anyway have the opportunity to at least make it, through high school, hopefully, depending on other circumstances, which compile on your healthcare disparities, being, environmental, family issues and things like that. So, it's historically known that those with lower levels of education tend to work less favorable jobs. Those that work less favorable jobs due to lack of education can be exposed to occupational hazards. Lower education levels and lower pay force individuals to crowded and sometimes unkept living arrangements. Not only this, too, sometimes not the most savory folks in the world live in some of these areas too, so you're exposed to maybe just not only unhealthy living conditions, but unsafe living conditions, where maybe you or your children are exposed to drugs and violence and things like that. So seeing this right here, I know probably, engineers and all these folks are probably rolling their eyes at this thing right now. But, top 10 OSHA violations for 2019, look at that. Number 5, respiratory protection. Right. Come on. So respiratory protection, a lot of these folks you will see with mixed mixed restriction, obstruction, or they have a COPD diagnosis and their ratio is 120%. And asking me, what'd you do for a living? They'll say, well, I worked at the cigarette factory, or I worked at the aluminum factory. Okay, did you wear a mask or anything like that? Well, Lord, no. Well, sure enough, right? So to a fault of their own, but also, again, as we see with risky behavior, lower education levels, and lower income, they're all just mixed in together. But yeah, I was just looking it up and thought, well, sure enough, I bet you. Pulmonary health and risky behavior. Believe it or not, look, when I was growing up, this was, I promise you, us little heathens running around trying to smoke cigarettes and whatnot. 30% of health disparities are caused by health behaviors. That's a pretty significant statistic, right? 30% of health disparities are caused by health behavior. So kind of like we were talking about, sedentary lifestyle, fast food, smoking, drinking, substance abuse, right? Irresponsible sexual behavior, an injury due to violence, certain mental health. So you can do so many methamphetamines that you become paranoid, right? These are all self-inflicted portions of your care. These are all self-inflicted And when you come into the hospital, what are they going to tell you to do? Cut it out, right? You know, you have patients that'll say, well, don't tell me quit smoking, you'll take away all that I got left, right? But you could at least say, hey, you should probably stop smoking methamphetamine. That's a good start, right? 30% of health disparities are caused by health behaviors by the patients themselves. And just like I like to state in our ethics course, at some point, every single one of us will be impacted by healthcare at some point in our life. But for 30% of the disparities, it's what we do during our life that's causing it. So yeah, a number of studies, numerous studies have found increased odds of child overweight, or if one parent is overweight. And pretty much what this is saying is it's saying exposure, right? So if one of the parents is obese, it's likely that the child will more than likely be obese too. We'll call this a generational behavior trait. It's in Kentucky, we'll say we have welfare families where they pretty much just train themselves to stay out of work, to get on disability and things like that. And they know how to abuse the system. But in this way, if a parent is obese, or if a parent smokes or so on, or if a parent's smoking methamphetamine in the house or selling food stamps or what have you, it's likely that that child might run into that same type of behavior and likely to live in poverty and be uneducated as well. I'm pretty sure there's probably a picture of me like that somewhere, I promise you. Back in the day, it was mean little kids. Higgins stated, one unhealthy behavior pattern that stands above all others in terms of long-standing and devastating impact on individual population health is smoking cigarettes. Folks, we know that. All of us respiratory therapists, we know that. And that's the thing. I like where Higgins stated, it's become so normal that Americans are sensitized to it. It's one of those things where you just see somebody smoking. For me anyway, I can smell it a mile away. And you don't really think anything of it. I don't think anything of it. All of my parents smoked, my grandparents smoked, things like that. And it's just been ingrained into, again, the culture of our society. But it is absolutely devastating. COPD creates a huge health burden in the United States. Contributes billions of dollars to the expenditure and costs just as much in terms of readmission. And you got to look on the back end too with families as well. So, and that's just like I tell my patients, you know this, you know what's going on, you know what smoking does. A couple solutions, maybe one way that we can change can be implemented when it comes to health disparities is through policy intervention. Some of us may know that efforts to ban that's like Juul and the flavored cigarettes and all those things. Policy intervention it makes it harder, but we have to look at history in some term. We look at prohibition of alcohol and things like that. There will be a way to do it, and sometimes it is just as unsafe to get it off the street than it is to store. But complete policy intervention on many different levels is needed. I don't know if I'll see it in my lifetime or our lifetime, but some serious changes is needed in policy. Transitioning from a volume-based to a value-based system and payment model of healthcare will be one of the most important efforts in healthcare delivery in the coming decade. That She and Singh in 2016, they stated the same thing in their book they wrote together in 2019. just iterated a bit differently. And many of the leaders in healthcare industry now are focusing on this value-based because it is informative in that, for one, the patients are becoming more involved. And what that means is they're able to input more. Like I stated with HCAPs and IQRs and things like that, they're getting more involved. And if you have 10 patients on Yelp, or 10 patients, you had 10 people on Yelp says, yo, don't go eat at this restaurant. Well, you probably ain't going to go eat at that restaurant, are you? So that's one way. Another way that makes it competitive against hospitals in terms of cost cutting, in terms of quality, in terms of outcome, in terms of services rendered. So I believe as well that this value-based system will be more in tune with the need of the current customer population base. Community-based interventions can come in the form of civic engagement using organizations, collaboratives in the form of coalitions. So in my studies, I learned about what's known as the community will. And essentially, folks, especially as healthcare providers, the more in tune we are with our immediate community, the healthier they're going to be, regardless. Some folks, I always say, sometimes I have tidbits of information that nobody cares about, but I'll tell them anyway. All of us have that, right? And we can spread our knowledge, we can educate our communities, and we can start things up. With us navigators out in North Carolina, we had a physician come out and did free PFT, or rather free handheld spirometry. It was very neat. It was a very neat process. Patient socioeconomic situation can simmer this bias and lead to better outcomes. Studies show a strong correlation in regard to obtaining the mentioned situational information and greater concern about inequality. There are there are actually 8 studies, but 5 studies show that attributing poverty to situational forces is associated with greater concern about inequality, preference for egalitarian policies, and inequality reducing behavior. Generally, what we're talking about here is that we know what areas are stricken with poverty, and this is just a matter of segmenting care in a way. But we know which populations are needing this. You're not going to set up I wouldn't think, I don't know anything about Florida, but you wouldn't set up a COPD clinic on the beach of Florida, on a beach in Florida, if the rates are low, right? You're gonna target these populations, and particularly you want to target what would be your largest population when you're looking at disability and things like that, which is going to be your older population, your rural population, and those with chronic disease. And that's just one of those solutions. We see where we need that. I mean, there are maps in regards to poverty all over the internet. Improving diversity, inclusion, and cultural competency of the nation's healthcare workforce is a major component of public policy intended to reduce health disparities. And just like I said, with certain, as the melting pot, there are certain cultures that some individuals may not be familiar with. I know that when I went from my small town to a big town medical center, I was exposed to a lot of different things, and I had to work my way around it and understand it so that I could provide unbiased and the correct type of care in some situations. So we need to improve this. A lot of literature will point, do online modules, make sure if you have to take a test at the end of the module, I would say go one step further and do a role play type situation in that some of these cultural, if you have a cultural group or organization at your facility, get together and have that role play situation, right? Especially with the leaders, so that the leaders can inform everyone else as well. Because y'all, we know that when we go on, we do our annual training, A lot of the time it just doesn't change. You know what to click, you know how to get through it, but with role play, you can't you can't get out of that. We've got to see you do it, right? And that's one of those disparities that we've got to come across. We've got to get through it. With chronic diseases accounting for almost 2/3 of global deaths in 2011, the call to action on prevention and early detection of chronic disease is necessary. Folks, I mean, that just goes back to saying, let's just be proactive, not reactive. Always tell my patients, when you go to see your primary care physician, they say, oh, well, your blood pressure's been high 3 or 4 times on your last visits. We're gonna have to put you on the blood pressure medication. You say, now, wait a minute. That's your first sign that you need to change your way of living, right? So I don't want to say that these health disparities, 30% of them are self-caused, right? I don't want to say that we don't want to take full accountability of somebody else's misdoings. I feel like for sure there should be an accountability on the side of the patient as well. But that comes down to prevention, and sometimes that prevention doesn't happen because the education isn't there, or the access isn't there. I'm sure some folks would have a mammogram if the truck would go by their house or what have you. Some people just don't have the access in that way. So obesity being one of the largest, no pun intended, factors to other comorbidities and complications of other diseases. I mean, y'all, weight loss programs and the like of all sorts is a huge solution to a lot of the problems. And I won't just say weight loss programs. I would say, again, we'll go back to the infrastructure itself and wonder why, you know, there's a liquor store and a McDonald's on every corner, right? And I hate to bash McDonald's. It's just the only one that ever comes to mind. So weight loss programs and all the like that it comes with are highly needed. Tobacco cessation programs, folks, I cannot tell you how much we need the true tobacco cessation programs in your community. I mean, trickled all throughout the United States. We need the cessation specialists. We need folks trained to get these people to stop smoking. The information's there. A lot of the times they just say, well, I've tried this and I've tried that and I just can't stop, right? True tobacco cessation policy with you would like to hope would be very nice for us RTs, with the ability to order certain nicotine replacement medications under physician. That's totally needed. I don't know if anybody's ever used the Fagerstrom nicotine dependence score, but it's a guideline there for the ordering mechanism itself. Physical fitness programs, or those are all examples, but y'all, physical fitness programs, that's great. That's awesome. But let's look at pulmonary rehab programs, right? A significant amount of patients are just not referred because, one, a lot of times they won't take the time to really dive in and see what the patient needs. They kind of rely on everybody else to do so. Thankfully, in my line of work now, I'm able to refer almost every single patient that I see. I can put in, call the pulmonary office and say, hey, look, buddy, they need an updated PFT and they want to go to pulmonary rehab, and they get it lined up. Now, the thing about pulmonary rehab is access itself. A lot of times it's 2-3 times a week. So we need better access in that way too. That goes back to technology though. Some of those folks, even if they can't get there, you take it to them, they still can't get it. So we have to be proactive, not reactive, right? So in that instance, we know those two barriers exist. So what would be the next step in getting through those solutions? Emphasis on preventative medicine, of course. If we have to practice curative, then overcome the obstacles. So we look at like alpha-1, right? Alpha-1 antitrypsin, right? I don't know if anybody has seen the lecture on that, but I think it's pretty nice. You should go check it out. But there is no curation to it. There's no way, right? So we look at gene editing and things like that to be curative, and not therapeutic, right? In preventative medicine, we want to look at, we just don't want to have to cure anything at all. That would be very nice, wouldn't it? But we keep dumping this preventative medicine in here, and curative medicine just isn't doing its job. It isn't catching up with the times. And again, for instance, with alpha-1, all it is recombination therapy, right? So curative being, if they just let us do our gene therapy, do our gene editing, maybe we can eradicate it altogether and cure this situation, especially in that case that is underdiagnosed and affects millions of people worldwide. So one of the solutions, we have to practice curative medicine. We have to focus on the cure and not band-aid everything up. So, of course, right, the cycle of environmental healthcare disparities, limited education, limited employment, limited empowerment, limited income, and this just fumbles in every other step. Excuse me. We have limited choices in where we live, limited infrastructure, limited services. Sometimes even if you do get into an infrastructure, they're not going to serve. Say if you have mold in your house, it may take them a year to even get to you. Residential characteristics, we look at older houses, again, environmental factors, whether increased toxins, increased stress, all these things trickle down into our births and our children and into the next generation. And I know that they've tried, but these barriers are still existing. So we would have to say it's a generational thing. But look at where it begins, right? So roughly 30% of it's our healthcare behavior, right? 20% of it's healthcare itself being a huge barrier. But look at our socioeconomic factors and our crumbling infrastructure around that. Even so, like I said, I have a means of providing transportation to some patients and things like that. Even at that, it is so overwhelmed with patients that need it that sometimes you just can't get folks in. That's again another socioeconomic factor. Where our physical environment, I feel like maybe there needs to be a redistribution. So we look at our physical environment, and it has to play a larger role in that, right? Has to play a larger role in that. And I say this because just look at the amount of chronic disease that there is, what people have been putting in their bodies and things like that. And sometimes even I'd say it can't be contributed to health behavior, certain types of medications that then fumble out and say, oh, well, this has actually been known to cause this and do that. I think that it would have to fall into our healthcare or something like that. But as it stands, our socioeconomic factors and our health behaviors and they're interlinked together, of course. I mean, you can live in the worst neighborhood in the world, and you still eat right and do things. It just comes to priority and focus, and if your health is in your interest. But living in those types of situations, your health is not your most important concern. So what have we really learned, or what have we went over? What did we want to look at? Healthcare costs do not match our outcomes, right? I mean, CMS and other governing bodies are stating that we're going to go up to 20, 25, 30% national GDP. I just don't think it's sustainable. And if we look at healthcare, we need some form of sustainability, some form of give and take that is symbiotic, as opposed to, it sometimes takes people's livelihoods. There are a number of factors involved in getting a patient the care that sickness requires. Sure, they can have insurance, but they might need a ride. If they've got a ride, do they have a provider? If they've got a provider, can they get to that provider? Is it in a timely fashion, right? If they get to that provider, does that provider have all the things necessary that they need to treat the patient? So, and it just goes on and on and on and on. And these are things that have been happening for a long time, and there's just a lack of infrastructure in place. Health policy is generally unclear and confusing. I think that is one of the biggest factors in with patient interaction with healthcare, but in particular too, with employee interaction with healthcare. Sometimes we're uncertain of what we should be doing. We have to consult ethics committees and things like that. So healthcare policy is unclear, it's confusing, it's hard to follow. Most people do not understand their own care. Like I stated, roughly 12% of the American population is considered health literate. That statistic there just kind of blows the top off for me. You go to the hospital, you don't know what's going on with you. The providers and the clinicians and everybody's talking what would probably seem like mumbo jumbo. You start to feel better, they just send you home, give you a printout of a bunch of words you don't know and medicine you can't pronounce, and send you on your way. Well, of course, you can see how people just don't comply with healthcare. Education and income are two of the greatest influences on health and healthcare disparity to date, right? And we could keep going over education and income and how it's linked to generally every other disparity that we see. Well, besides gender and ethnicity and things like that. Solutions are in abundance, policy change, more physicians. And here's the thing about physicians. So the MCAT is a very, very, very brutal exam, first off. Second off, there are now more and new exams that people have to take to even become physicians. So I don't know if this is some kind of back end play to get doctors out and only hire advanced practitioners, including us respiratory therapists, or what's going on there. But if there is a significant lack of physicians and RTs and nurses and all these things, we'll flood the market for a minute and see what happens. Better reimbursements to the physicians. If a physician can make a good living in a rural area, well, they're going to probably stay there, right? So not all of it is, CMS has got to pay a little bit better too. But with things are so tight, we want high outcomes and low costs, but we're having low outcomes and high costs. So they're not sure probably what they're doing either. Well, we're going to pay you what you think we should pay you. Here's your DRG. Value-based care and accountable care organizations. The literature is flip-flop on ACOs, but value-based care pretty much it's cost savings at higher outcomes. That is the general force of it. Community outreach and more, folks. Healthcare disparity is rampant, and somebody from a rural area, I know this myself, right? I've had to travel an hour, 2 hours to see a specific physician. Birth of my child, we had to drive an hour and a half because there were no physicians readily available in our immediate community. So I feel it. I'm sure everybody else has felt it. And if you don't think that you've ever felt or been a part of some type of healthcare disparity, just take a look at your care and think about it and get back with me. Folks, I appreciate everybody coming. Hope you learned something. This is one of my favorite topics. Reach out for, collaborate, whatever you want to talk about it. And I will hand this back over to Keith.